All right, so at this time what we're going to do is we're going to move on and we're going to go to acid-base balance. So we already talked about the carbonic acid. So carbon dioxide in water, reversible reaction, a hydrogen ion plus a bicarb molecule. Now there's a couple different buffering systems in your body, but this is one of the major ones, and it explains why arterial blood gases work the way that they do. So earlier when we talked about bicarbonate levels, we said that you can tell if your blood is going more acidotic or alkalotic, but you can only see a process. And what process do we describe that as? Start with an M. Metabolic. So you can see if there's a metabolic process that is pushing your blood in one direction or the other. But you can also have respiratory processes that shift you one way or the other also. Remember, we just had you hold your breath, and as you were holding your breath, what was accumulating inside your blood? Carbon dioxide. And when you have excess levels of carbon dioxide, that produces acid. So your lungs are responsible for getting rid of carbon dioxide. Every time you do that, you decrease the amount of acid floating around in your blood. So breathing out decreases acid levels. Holding your breath, or not breathing enough, increases acid levels. So we also have respiratory acidosis, alkalosis. So with venous blood, when you check the bicarb levels, all you can tell is metabolic. You can't tell respiratory. In order to tell respiratory, we need arterial blood. And that's what we're going to talk about now, is arterial blood gases, or ABGs for short. So the first thing we need to know is the normal values. So oxygen, anytime you see this P in front of a gas, it means pressure. So the pressure of oxygen is greater than 80, that's normal. The pressure of carbon dioxide is going to be 35 to 45. pH is going to be 7.35 to 7.45. And then your bicarb level, and now it really is bicarb, is going to be 22 to 26. So those are the normal levels, and what we're going to do is we're going to use those to analyze some blood gases to try and figure out whether the problem is a respiratory problem or a metabolic problem. So in order to make this work, there's a 4-step process we're going to work through. So the very first step in our process is to label everything. So I'm going to give you some sample numbers here. All right, so this is a high or low? It's normal. This? Low. This? Low. And normal. All right, so PO2 of 90 is normal. PCO2 of 33 is low. pH of 7.33 is also low. And then bicarb level 24 is normal. So we have two abnormal things. How do we label those? When you dissolve carbon dioxide in water, what does it become? Carbonic acid. So carbon dioxide becomes acid. Our acid level is low, so therefore we have what? Alkalosis. And what's in charge of dealing with carbon dioxide? What organ? Lungs. So we're going to call this respiratory alkalosis. Sorry. Yeah, that's right. Although I did these numbers wrong. I'm a loser. Okay. There we go. Now the numbers make sense. So pH 7.48, is that above or below normal? Above. And so remember that pH is the higher you go, the more alkalotic it is. So this is the overall balance in the body. And so we're going to call this alkemia. Emia meaning of the blood. So it's a total alkemia of the blood. And then this last one is nothing. So then now because this is a simple situation, you only have one problem and you can see that it's causing it. So we have a respiratory problem causing an overall alkemia. Does that make sense? So you've got respiratory alkalosis causing alkemia. How could that happen, you ask? How can that happen? Well, in order to get rid of carbon dioxide, what do you have to do? Breathe out. So imagine that you're in health assessment class and you're sitting on the table. Take a deep breath. Take a deep breath. Take a deep breath. And how do you start feeling after about 5 or 6 of those deep breaths? You feel a little woozy, a little dizzy. What's actually happening is you're taking so many breaths, so many big breaths in such a short time that your carbon dioxide level is actually going down just a little bit, making you slightly alkemic, which in turn is why you feel a little bit lightheaded. So that is this situation exactly. Now this one was pretty simple because we had one problem and one result. The other one was normal, so there's no possibility that it was anything else, right? Okay, so that's the most simple example. And in this case, after you did step 1, you pretty much knew the answer. But it's not always that simple. So let's look at what happens if we change one thing. Let's take our bicarb level, and let's change the bicarb level to 18. Now, is that high or low? Low. That's low. Now, what is bicarb? Is it a base or an acid? Base. It's a base. So when the base is low, that means our patient is acidotic. So, and what's in charge of making bicarb? Which organ? The kidneys, which makes this metabolic. So bicarb is always metabolic. Metabolic acidosis. So now step 2 is we're going to match our emia to our osis. What the heck does that mean, Dr. Heyman? All right, the pH is the overall balance of the blood, right? You have 2 processes going on in the body. One metabolic, one respiratory. One of them is pushing towards acid, one of them is pushing towards alkalosis. Which of them is winning? That's going to show up in the pH. Does that make sense? So one is pulling one way, one's pulling the other way, and the total is the pH. So the pH is expressed in terms of emia. The processes are expressed as osis. So whichever is the emia is the one that's winning. So what's our emia? It's alk. So which of these 2 osises is alk? Respiratory. So what is our problem? What's our primary problem here? It's a respiratory alkalosis. So our underlying problem is respiratory alkalosis. So now we've got to move to step 3. which is what's called compensation. So we've got a respiratory problem that is pushing us alkalotic. Now, does your blood like to be alkalotic? No, it wants to be neutral, right? So what's it going to do? What's your body going to do about that? Help, I'm becoming alkalotic. What do we do to prevent from falling over? We're going to compensate in some way. Now, ordinarily, your kidneys produce bicarb, which buffers acid. But here, we don't have enough acid. So the way the kidneys are going to do that is they're going to decrease the amount of bicarb they produce. Does that make sense? Now, the way that you tell that on an ABG, so we matched alkemia to respiratory alkalosis. So now we've got to look at the other osis. So if respiratory was our primary problem, what's metabolic doing? Is it the same, neutral, or opposite? It's opposite, which means that our kidneys are compensating. So step number 3, you're looking for compensation at the other osis. So our respiratory alkalosis is our primary problem, and our kidneys are, what's that keyword? Compensating. So we'll say compensated respiratory alkalosis. Does that make sense? All right, there's one more piece. Are our kidneys able to fully compensate, or are they only partially compensating? And the answer to that, step number 4 is we have to look at the pH. So, what's normal pH? 7.35 to 7.45. And is that in that normal range or outside of the normal range? It's outside of the normal range. So even though our kidneys are compensating, are they compensating enough? No, they're not. So that makes it partial. So we have partially compensated respiratory alkalosis. So what does that mean for our patient? Our patient has some condition that is causing them to breathe out more carbon dioxide than usual. That, in turn, is being compensated for by your kidneys. Now, one thing we need to know about kidneys versus lungs. Lungs can change instantly. If you hold your breath, how long does it take before you start feeling it? Not long. 30 seconds, a minute. If you start taking too many deep breaths, how soon do you feel woozy and lightheaded? Like 5 to 10 seconds. So your lungs can compensate, they can change in seconds. It takes your kidneys a couple days to compensate. So, because we have compensation by the kidneys here, how long has this respiratory alkalosis been occurring? Probably for a few days. Does that make sense? So what this ABG is telling us is, number 1, our lungs are the problem. Number 2, our kidneys are trying to compensate. And number 3, it's been going on for a couple days. Does that make sense? Okay. So now what we're going to do is we're going to erase all these numbers, and we're going to do a couple other examples. Okay, so we're going to do this ABG. So 60, is that high or low? Low. PCO2, high. pH, low. And bicarb, high. All right, so what is the term for low oxygen? Hypoxemia. Now, what is the difference between hypoxia and hypoxemia?
Hypoxia is in the tissue, hypoxemia is in the blood.
All right, so Hypoxia is in a tissue, so for example, your heart, your brain, or muscles. And hypoxemia is low oxygen everywhere. So depending on the location of hypoxia, you could die from a stroke or from a heart attack. But with hypoxemia, you have the potential to damage everything at the same time. So that's hypoxemia. Then elevated carbon dioxide. What is carbon dioxide? When you dissolve it in water, you get carbonic acid. So carbon dioxide is acid. So elevated acid levels would be called acidosis. And which organ is responsible for that?
Respiratory.
Lungs, respiratory. So we have respiratory acidosis. Now, what's the pH?
Low.
That's low. Is that acid or alkalinity?
Acid.
That's acid. So acid, now what's the suffix there? Emia. So acidemia. Now this one, bicarb levels. Bicarb, is that a base or an acid? It's a base. So high levels of base, metabolic alkalosis. All right, so you've got two osises, a respiratory acidosis and a metabolic alkalosis. Which one of them is causing the problem? Which one?
Respiratory acid.
Okay, so acid, acid. So we're matching the emia to the osis. So our problem is respiratory acidosis. So now, step number 3. So we've looked at the respiratory acidosis, that's our primary. What's the other osis?
Alkalosis.
It's alkalosis. So is that compensating?
How do you spell alkalosis?
Alkalosis. Alkalosis. So, is alkalosis the opposite of acidosis?
Yeah.
Why, yes, it is. So that means that our kidneys are compensating. So we have compensated respiratory acidosis. Now, step number 4, we look at the pH. Is the pH within the normal levels or not?
No.
No. So is it partial or complete?
Partial.
It's only partial.
So it would be complete if the pH was in normal range.
Yeah, we'll do that in just a moment. Okay, so what this is telling us now is that the primary problem is that we are not breathing enough. Therefore, our body is retaining carbon dioxide and not obtaining enough oxygen. I guess we should also put that down here. And hypoxemia. So what's the primary problem? We are not breathing enough. That's causing the retention of carbon dioxide and not enough oxygen. Our kidneys are trying to compensate by producing more bicarbonate. But are they able to do enough? No. So it's only partial. Now, what do we know about kidneys? How long does it take for them to compensate? Days. So this problem has been going on for at least a couple days, maybe even years. Now, we haven't talked about respiratory problems yet, other than COPD. But what is COPD? Chronic obstructive pulmonary disease. Does that make it easier or harder to breathe?
Harder.
Harder to breathe. So if you're finding it hard to breathe, do you think that COPD over time could lead to elevated carbon dioxide levels?
Yeah.
Sure. So that is a potential cause. Now, have we learned about any drugs that reduce your drive to breathe? Yes, what are they?
Opioids.
Opioids. So is it possible that chronic opioid use could potentially lead to not enough air exchange, which in turn could lead to not enough oxygen. It's possible. I mean, people die of overdoses for that exact reason, right? So you've got two possible respiratory causes that you can think of right offhand. So what this arterial blood gas allows us to do is see which of these is causing the problem. Is it metabolic or is it respiratory? And then it also lets us look at the compensation. So let's change one thing to take a look at compensation. If we make this 7.35, so the pH is now 7.35. Nothing else changed. What would the difference be here? Is that acid or is it base now? Well, it's in the normal range. Now, is it leaning more acid or is it leaning more alkalotic? It's leaning toward the acid. So I like to call that acidemia-ish. Because it's not acidic, but it's kind of going that direction. So now everything else stays the same. We've got compensated respiratory acidosis with hypoxemia, but is it complete or is it partial compensation? Because the pH is within the normal range, it's now considered complete compensation. So we'll say completely compensated respiratory acidosis with hypoxemia. Please do not forget the oxygen status, especially if the oxygen status is low. Not having oxygen will kill you, right? Right? So the very next topic we're going to do is respiratory, and that means that you've got to know, you can't be ignoring the respiratory factor of oxygen just because, well, it's not acid base. Well, we're doing the whole ABG at one time. Does that make sense? So, completely compensated respiratory acidosis because the pH is within the normal range. All right, so at this time, what we're going to do is we're going to do a couple more, only I'm not going to do them. Ashley, come on down. All right, I'm going to give you some numbers here. Yeah, you can bring your notes if you want to. All right.
All right.
So go ahead and label those. Step number one.
Normal, that's low.
All right, you're standing right in front of the camera.
Sorry, I didn't know I was on camera.
Okay, so we've labeled oxygen is normal, carbon dioxide is low, pH is low, and bicarb is high. So what do we call each of those things now?
So this would be respiratory alkalosis.
Okay, so carbon dioxide is acid level is low, so respiratory alkalosis. pH.
That would be, it's more acidic, so acidemia.
Acidemia. And I cannot do ABGs today. So hold on, I'm going to change that number for you, make that a 15. So bicarb is 15, which is low. And what do we call that?
That's metabolic acidosis.
Metabolic acidosis because bicarb is a base. The amount of base is low, so therefore metabolic acidosis. All right, so you have an emia and two osises. Which one of them is your primary?
The metabolic acidosis, the acid.
All right, so the overall is acidemia. So that's going to match your metabolic acidosis. So what's your primary problem?
Metabolic acidosis.
Metabolic acidosis. You love to stand right in front of the camera.
I'm gonna move.
All right. So metabolic acidosis. Now, so go ahead and cross that out since you've dealt with it. So we're going to cross out the metabolic acidosis. So what is the other osis?
Respiratory alkalosis.
Is that the opposite of acidosis?
Yes.
Yes. So is it compensated?
Yes.
Yes. So go ahead and write down compensated. All right. So for the bonus prize, is it partial or complete?
Partial.
How do you know?
Because it's out of the range of pH.
Okay, so the pH is 7.31, which is outside of the normal range, so therefore it's partial. All right, now, what's the primary problem?
Acidosis.
Acidosis. What kind of acidosis?
Metabolic.
Metabolic. So what's causing this acidosis is not a respiratory problem. It's some other kind of problem. It might be kidneys, it could be throwing up, it could be diarrhea, it could be burns, but it's something metabolic, not respiratory. Does that make sense?
Yeah.
All right. Now, just a quick extra question. Because your lungs are compensating, and how are our lungs compensating? By decreasing the amount of carbon dioxide. In order to decrease carbon dioxide, do you breathe more or less? You breathe more. So when you look at the patient, what might you see? You might see elevated breathing rate or deep breathing rate, kind of like a Kussmaul breathing. So that would be another potential example. I'm going to do one more. So Mireya, come on down. All right, let's see if I can do numbers right. Okay, I think I got it. And I got the fly.
Okay, that's normal.
Okay, so 95 oxygen is normal.
And this is high,
Okay, so 48 PCO2 is high.
so that's respiratory acidosis.
So respiratory acidosis. I have to repeat everything you say so it can be on camera.
And this is high, so this is a base, so it's alkemia.
Okay, so pH of 7.47 is high, so alkemia.
And this is high, and that's a base, so alkalosis.
All right, so bicarb of 33 is high, so metabolic alkalosis. Okay, don't forget to write down your words, respiratory and metabolic. As you get better, you can skip steps, but for now, I want you to do the full process because you'll be less likely to confuse yourself that way. If you just skip to the end, sometimes you end up confusing yourself. All right, so what is our overall emia?
Metabolic.
So
Alkemia.
alkemia. All right, so does the metabolic or the acidos or the respiratory match that?
Metabolic.
Okay, so what's our primary problem then?
Metabolic alkalosis.
Metabolic alkalosis. You know, you write a little too big.
I do. Oh, you're being sarcastic.
Yes. All right, so metabolic alkalosis is the primary problem. And if you look at the other one now, is the other one the same or opposite or normal?
It's opposite, and it's partially compensating.
Oh, well, okay, so it's compensated. So go ahead and write down compensated. So step 3, we looked at respiratory, and respiratory is compensating. And then the last question is it partial or complete?
It's partial,
How do you know it's partial?
because the pH is not normal.
Because the pH is outside the normal range, okay? So partially compensated metabolic alkalosis. All right, so the underlying problem in this case is a metabolic problem, and our lungs are compensating, but only partially. So what sort of problem could cause a metabolic alkalosis? And probably the most common one would be vomiting. What is your stomach acid made of?
Bile?
Not bile.
No.
That would be bile. Hydrochloric acid. So when you vomit up hydrochloric acid, you're losing acid. Right. So you're losing acid. So that could cause a metabolic alkalosis. At the same time, you're losing hydrochloric acid. So if you looked at an electrolyte panel, what electrolyte would probably be low? Chloride. So in vomiting, you will often get a metabolic alkalosis with hypochloremia. Not always. Vomiting is weird. It can go either direction, acidotic or alkalotic. Just depends whether you're losing more bicarb than hydrochloric acid. But so it can go either way. But when you see this metabolic alkalosis, one of the first things you should think is, could this patient be vomiting? Does that make sense? All right, and it's partially compensated. So that means that our lungs are doing what? They are holding on to carbon dioxide. So if you look at the patient, you might see that their respiratory rate is lower than usual. Or they might just be taking shallower breaths than usual. All right, we're going to do 2 more, and then we're going to be done with ABGs. All right, so let's do, let's see. Okay, so oxygen level is 93. Our PCO2, carbon dioxide level, is 32, which is low. pH is 7.37. Is that high or low? Well, it's in the normal range, but 7.4 is exactly center, and it's more acidic than that. So that makes us what? Acidemia-ish. And then the bicarb level is 16, which is low. Low bicarb, low base. That means we're metabolic acidosis. Carbon dioxide was low. Carbon dioxide is an acid, so low acid. That means we've got respiratory alkalosis. All right. So our emia is acid. And which of the 2 osises is acid? The metabolic. So we have metabolic acidosis. If we look at the other osis, so respiratory, that's alk. That's the opposite of acid. So therefore we are compensated. And then we look back at the pH, and it's ish because it's in the normal range, which means it is completely compensated. All right. Any questions about that particular one? So in this case, we have a metabolic problem. That's our primary problem. And our lungs are compensating completely to maintain acid-base balance. All right, one last one. By the way, there is a worksheet for electrolytes and for arterial blood gases on my website. You should download that worksheet and do some problems. And then in class, we'll go over the ones that you have questions about. All right, are you ready for the bonus prize? Let's see what you got. All right, so we'll say that PO2 is 68, PCO2 is 53, pH 7.29, and bicarb 14. Okay, PO2, low. What do we call that? Hypoxemia. Carbon dioxide of 53, that's high. And so respiratory what? Acidosis. pH of 7.29, low, which is acidemia. And then bicarb is low, which means metabolic acidosis. Okay, step number 2, match the emia, which is acid, to osis. Oh my gosh. Oh, it doesn't work. Why doesn't it work? Oh my gosh, something's wrong. We have metabolic and respiratory acidosis. What does that mean? It's both. We call that mixed acidemia. So, in this case, the patient has a respiratory problem pushing them towards acid, maybe COPD. They also have a metabolic problem pushing them towards acid, maybe diarrhea. So there's 2 problems, both pushing towards acidemia. So is there any compensation at all? No, because they're opposite. Sorry, they're not opposite, they're the same. So both of them are acid, osis.
Why are they both mixed acidemia and not acidosis?
Oh, okay, sure. Mixed acidosis. So mixed acidosis. All right, I just realized we should probably do one more just for fun. You ready for it?
Wait, is there anything with the, I know you said that the pH, there's no other, this is the pH
Yep.
is low.
Now, at this point, because you've got mixed, you stop at step 2.
Okay.
You don't, there's no need to go to step 3 or 4.
So would we still put that in hypoxemia?
Say again?
Would we still put hypoxemia in?
Yes, you also say hypoxemia. All right, in this case, we're going to do 91 for the oxygen, 37 for the CO2, 7.33 for pH, and then bicarb will be 19. All right, so oxygen levels, 91 normal. PCO2, 37, normal. pH, 7.33, low acidemia. Bicarb level of 19, low metabolic acidosis. So what's our primary? Acidemia matches with metabolic acidosis. So our problem is metabolic acidosis. Step number 3, we match the other osis. There isn't another osis. So what does that mean?
It's compensated.
Uncompensated. So in this case, there's a metabolic problem pushing the body towards acidosis, and the lungs are doing nothing to compensate. Maybe because they can't, maybe because you've got some problem in your body that's just preventing that compensatory mechanism from happening. Does that make sense? All right. No, just uncompensated. All of the partially or completely depends on it being compensated in the first place.
So if we don't make it to the next step.
Right. You just stop there. Okay. So the last thing we need to do before we go on to respiratory is we need to talk about some combinations. So the first thing is acidosis. Now, our bodies are more likely to lean acidotic. What happens if you don't breathe enough?
You hold in carbon dioxide.
Well, you're producing carbon dioxide, so you become acidotic from that. So we're always producing carbon dioxide, leading us to be more acidotic. Now, what happens if you don't have enough oxygen delivery and you can't produce the carbon dioxide? You produce lactic acid, which leads our patient to become acidotic. So we're always moving acidotic. Doesn't matter whether you hold your breath or not, you're always moving slightly acidotic. So our bodies are primarily geared towards buffering and removing acid. We're not quite as good at dealing with the opposite problem because the opposite problem just doesn't occur as often. Does that make sense? Okay. So acidosis can be either a respiratory problem or a metabolic problem. So if we have respiratory acidosis, what would it look like? What's the number one sign of respiratory acidosis in terms of lab values? High carbon dioxide. Oh, I forgot to mention earlier. So this P in front of the carbon dioxide means pressure. And sometimes you'll see an A right after it, so it'll be PaCO2. The A means arterial, but we don't draw blood gases from venous blood, so it's kind of superfluous. It doesn't really matter that much whether you see the A or not, same difference. So, elevated carbon dioxide. So, why does the patient have elevated carbon dioxide? Because they're not breathing enough. So decreased ventilation. So what are some possible reasons why a person would have decreased ventilation? COPD. What else? Opioids. What else? Anesthesia. Give me another one. All right, asthma. What else? Head injury. Anything else? Well, I'm sure there's got to be something because you're saying what else? How about pneumonia? Okay, pneumonia. Okay, so you can see what all these things have in common. They're all related to breathing. Okay. Some of them are physical limitations on the lung themselves or the airway. Some of them have to do with the control of breathing, so like your opioids and head injury. And then anesthesia as well. So it's either you have a decreased drive to breathe or you have some sort of physical abnormality that's preventing normal ventilation. But one way or the other, you're not ventilating enough. So what is the ultimate solution to respiratory acidosis? Not necessarily give oxygen, because that's not going to change their carbon dioxide. Ventilate the patient. Now, whether that's giving them Narcan so they breathe on their own, or whether it's giving them albuterol so they can breathe better, or whether it's removing grape out of their bronchi because they aspirated, whatever it is, we have to treat that underlying problem and get them breathing more. Now, in some cases, like say anesthesia, we have to breathe for them. What's the fancy, how do we breathe for them? Okay, intubate and ventilate, right, you gotta ventilate them. So that would be how we treat respiratory acidosis. So at the more severe levels, you ventilate the patient. At the less severe levels, you support the patient's efforts to breathe. Now, what about metabolic acidosis? What would we see here? What's the primary lab indicator? Well, it's bicarbonate, and it's going to be high or low? Low. All right. What are some potential causes of metabolic acidosis? All right, diarrhea. What's the mechanism there? You're just pooping out bicarb. Diarrhea-ing bicarb. Urea-ing bicarb. So that's one. Give me another one. Vomiting. What would be the mechanism there? Throwing up bicarb. All right, give me another one. Diabetic. Ketoacidosis. Burns can also cause this by leaking bicarb into the interstitial fluid. Okay, so you're gonna have to treat those underlying processes. Now, in terms of alkalosis, we can have respiratory and metabolic. So under respiratory, what will we see? What's the lab value we would see? Low PCO2.
I have a quick question.
Sure.
So you said that CO2 before was bicarb, it is also HCO3. So
Only when you see it on venous blood. So electrolyte panel, basic metabolic panel.
So can we know that when there's a P in front of it, it's carbon dioxide?
Yes, anytime you see a P in front of CO2, it really is carbon dioxide, not bicarb. If you see CO2 by itself, really means bicarb. Okay. At least on any tests that you see here, and that's how you're going to see it in the hospital also. CO2 by itself is going to be really mean bicarb. So here, low PCO2, you're breathing out more carbon dioxide than usual. So give me some reasons why that could happen. Anxiety. Anyone ever have a panic attack? It's supposed to be an X. Say again? Exercising. Now that's an interesting one. As it turns out, you have increased metabolic activity, and so you're actually slightly acidotic in that case. So, no. Give me another one. Acute asthma attack. How would that cause?
Because you're anxious, or that falls into anxiety because you can't breathe.
But if you can actually breathe that much, then you would probably be respiratory acidotic because you can't breathe out. Yeah. Okay. Give me another one.
Are we talking about breathing too quickly or not breathing enough? We're talking about
Breathing too much.
too much.
Yeah. You actually haven't learned this, but Medea has. So.
Yeah.
Yeah. It's a pirate sound. ARDS. So we'll learn about ARDS soon, but acute respiratory distress syndrome. In this syndrome, you have low oxygen levels because there's a problem in the lung that doesn't allow you to get the oxygen in. Because of the low oxygen level, you breathe more. The carbon dioxide can get out just fine, you just can't bring the oxygen in. So that leads to, it is ARDS, but it leads to a respiratory alkalosis. So this is really what we should say is an oxygen diffusion problem. And we'll talk about that when we get to respiratory. All right, on the metabolic side, the biggest one is probably vomiting. And notice that you've got vomiting twice. Why is that? Why can it be both acid or alkaline? I don't know. What do you think? Well, you could become alkalotic because you vomit up
Too much.
too much what?
Bile.
No, not bile.
Acid.
Acid. What kind of acid? Hydrochloric acid. But you could become acidotic by vomiting up too much. You already answered this one right, by the way, earlier.
Me?
Yep.
Bile.
No, not bile.
Sorry, that's
Bi.
Bile.
Carb,
Carb.
right. So when a person is vomiting, they could be vomiting up more bicarb, become acidotic, or they could vomit up more hydrochloric acid and become alkalotic.
Okay, I don't think I'm understanding this because what exactly is bicarb?
Bicarb is HCO3
that.
negative.
What is in your body?
HCO3 negative.
It's not bile, but like what is it that you're throwing up?
All right. So bile is a specific stuff
That's made by your liver.
made by your liver. It's got bile salts and some other, and cholesterol and a few other things, bilirubin. Okay, that's bile.
Yeah.
Okay, bicarb, you can't see it.
Okay.
It's bicarb is the stuff that baking soda is made out of. Baking soda is sodium bicarbonate.
So we just need it in our bodies, or we make it in our bodies.
Your kidneys make it.
Okay. And then we just throw it up, or we don't. So
Yes.
It's made by the kidneys. Okay.
Right. It's made by the kidneys. It's in your blood. If you're vomiting up, you could be losing bicarbonate,
Okay.
or you might not. All right. Any questions about those items?
How would you treat those?
So how would you, well, you treat ARDS by treating ARDS. Panic attack, well, either they'll stop or they'll pass out.
So I should treat the underlying cause?
Yeah.
Okay.
Treat the underlying cause. All right, and now, here's a really, really important thing. If your patient has anxiety, and you can help bring their carbon dioxide levels up by having them breathe into a paper bag. What will that do? So they're breathing back their own carbon dioxide. So that kind of raises the carbon dioxide levels back up, help prevent them from passing out. So if your patient has low PCO2 because of something transient like anxiety, what can you do?
Give them a paper bag.
Have them breathe in a paper bag. Why not a plastic bag? Because we do not want them to asphyxiate, which is a fancy word to suffocate. So, now here's where you guys are going to fall into trouble potentially on your test, and you should not do this. If on a metabolic panel sodium, potassium, bicarb, CO2. So on the basic metabolic panel, you see CO2-18. Their carbon dioxide is low. I gotta have them breathe into a paper bag. Let me just say, I will smack you. I'm gonna take double points off for that one. Because first of all, CO2 on a basic metabolic panel really means what? It really means bicarb. And is that number high or low at 18? It's low. This patient is actually metabolic acidotic. And here you are trying to raise their carbon dioxide levels. You jerk. But you will be surprised how many of you will try and do this to your patients just because you hate me. I know, it's all about me. Well, you see, Dr. Heyman, if we just learn what you tell us and then get it right on the test, we would not be being true to ourselves. So therefore, we have to get it wrong just to maintain our integrity. So, when you see that carbon dioxide without a P in front of it, what does it really mean?
Bicarb.
It really means bicarb. So chances are, if it's lower than 35, well, lower than 22, it's actually acidosis. And you're treating it like it's PCO2, so you're going, oh, well, it's low, therefore I need to raise it. No, 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 no.
But either way, that's metabolic, that's not respiratory.
Yes, I know. But they treat it like it's respiratory because they're not in their head saying which really means bicarb. And believe me, I wish that they didn't report it as CO2. I wish they just called it bicarb, because it would make your job so much easier, which in turn would make my job so much easier. I wouldn't have to try and trick you on the test. I'm not tricking you, I'm telling you right now. And yet, many of you are gonna fall for it because you hate me. It's very sad to be hated so much. All right, one last thing I do need to mention for metabolic acidosis. What is metabolic acidosis characterized by? I just circled it in case you're wondering. Low bicarb levels. So, in addition to treating the underlying problem, what else could we give? IV, sodium, bicarbonate. So when your patient's got metabolic acidosis, in addition to treating the underlying cause, you can also give
IV sodium bicarbonate.
IV sodium bicarbonate. You can actually also give that over in the respiratory side as well, if they're not fully compensated. If they're fully compensated, there's no reason to give it. But if they're only partial or uncompensated, then you can give them bicarb to help compensate. All right, on that note, we are going to be done with acid-base balance. Cut!
Give IV hydrochloric acid when the hypoxia?
No, you don't give IV hydrochloric acid. But if you give normal saline over time, they will become slightly hyperchloremic.
I have that in my notes.
So are we done with fluid and electrolytes or no?
Say again?
Are we done with fluid and electrolytes?
We're done with fluid and electrolytes.